Welcome to the Rocky Mountain MS Center's webinar series, Maximizing Lifelong Brain Health in MS. Today's topic is the emerging and evolving field of neuroimmunology. This presentation features Dr. Piquet. Dr. Piquet is a graduate of Penn State University School of Medicine and completed her neurology residency at Harvard's neurology program at Massachusetts General Hospital and Brigham and Women's Hospital. She completed a Neuroimmunology Autoimmune Neurology Fellowship at the University of Utah. Dr. Piquet sees patients with autoimmune neurological diseases, multiple sclerosis, and other inflammatory diseases of the central nervous system. Her main clinical interest includes antibody-mediated disorders of the nervous system, such as autoimmune encephalitis and stiff person syndrome, as well as demyelinating disease, including multiple sclerosis and neuromyelitis optica spectrum disorder. She has additional expertise in the other inflammatory diseases, including neurosarcoiditis, vasculitis, and central nervous system complications of rheumatological diseases such as lupus and Sjogren's syndrome, among others. Dr. Piquet's research interests include optimizing diagnosis and treatment for patients with autoimmune neurological diseases. This includes the development of standardized guidelines and protocols for the diagnostic workup and treatment of autoimmune encephalitis. She is also interested in the identification of biomarkers associated with autoimmune neurological disease. This webinar is scheduled for 1 hour. The first 45 minutes will be the presentation. If you missed something on a slide, we will be archiving this webinar on our website, www.mscenter.org, so you can replay it at any time. We will reserve approximately 15 minutes at the end to answer questions from the audience. Please submit your questions throughout the presentation by typing them into the chat window on your screen at any time. We will answer as many questions as time allows. With that, I will turn it over to Dr. Piquet.
Thank you for the opportunity to speak today, and thank you for everyone who is on the webinar and listening live. My name is Amanda Piquet, and I appreciate that introduction. We're going to discuss the emerging and evolving field of neuroimmunology, specifically talking about what is autoimmune neurology. So the objectives today for the webinar, we're going to discuss what is autoimmune neurology. How do patients with autoimmune neurological diseases usually present? We're going to talk about different types of autoimmune neurologic diseases, and I'll provide some examples here today. And then we're briefly going to discuss how do you test and treat for these diseases. So just starting with some basics, we're going to first review what is the immune system. We need to understand what this is and how the interplay between the immune system and the nervous system can cause autoimmune neurologic disease. There are two main parts to the immune system, the innate immune system here. And basically the innate immune system, you were born with this. It will fight any foreign infection, virus, or bug right away. It's your first defense. The other component to the immune system is the adaptive immune system. That's mainly where the focus is going to be today. There are two cells in the adaptive immune system, B and T cells. The adaptive immune system is created in response to a specific exposure, meaning it can take a few weeks to kick in, but when it is activated, it is very targeted and specific and aimed at a very specific target such as a virus or a specific microbe. We are going to focus on the B cells right here. Mainly today, the B cells produce antibodies. So what is an antibody? An antibody is an immune globulin or protein produced by the immune system to help fight infection. When the immune system misbehaves, then antibodies are created by the immune system that attack yourself rather than a virus or infection. Autoimmune neurology is one of the most rapidly evolving fields in neurology. Antibodies that target the central nervous system include a variety of diseases that are distinctly different from multiple sclerosis. This is a group of antibody-mediated diseases that are caused by these autoantibodies that recognize the nervous system as self-antigen, ultimately causing the immune system to attack oneself. The focus on today's talk will be when these antibodies attack the brain and the spinal cord, what types of diseases present. These diseases can be idiopathic, meaning we don't understand why they happen, no apparent trigger. They can be para-infectious, meaning triggered in the setting of a certain infection, or perhaps cancer-related, also known as the paraneoplastic syndromes, in which you produce antibodies in response to a cancer in the body. The idea of paraneoplastic or immune-mediated mechanisms causing neurological syndromes in the setting of cancer was actually first described in the 19th century. It wasn't until 1965 Dr. Wilkinson and colleagues discovered a neuronal antibody in 4 patients with small cell lung cancer that caused a sensory neuropathy, as you can see here, anti-Q. Then it wasn't until the 1980s when studies began describing specific neuronal autoantibodies found in the context of different antibody syndromes, and this really began to accelerate. In 1983, Drs. Greenlee and Dr. Brashear identified another Purkinje cell antibody in patients with ovarian cancer causing cerebellar degeneration. Then in 1985, a group with Dr. Posner began describing different paraneoplastic neurologic syndromes in patients. Then in 2004, neuromyelitis optica, or NMO, seen here, was described in the setting of a positive aquaporin 4 antibody, which was also identified and known as the NMO antibody. And this is with Dr. Van der Lennen at the Mayo Clinic. Initially, NMO disease was thought to be a form of multiple sclerosis before the discovery of this antibody, but it is very clear now that NMO is a distinct clinical and pathological disorder. It is true that NMO can initially present very similar to MS, often mimics MS. Patients often present with optic neuritis and spinal cord lesions, but it's very important to differentiate these two diseases because they have different treatments. And we'll discuss this a bit later in the presentation. Then something happened in 2007. The field of autoimmune neurology just exploded. And this was after the discovery of NMDA receptor antibodies with Dr. Dalmau's group. And he identified this antibody in 4 young women who developed a syndrome of memory deficits, psychiatric syndromes, decreased consciousness, and respiratory problems. These 4 young women were found to have ovarian teratomas. Since this time, however, NMDA receptor encephalitis is now described in children, in men, and in women without teratomas. Beyond NMDA receptor encephalitis, other antibodies against cell surface antigens have been identified with increasing frequency. This is all highlighted here with red. The discovery of these cell surface antibodies has really shaped the landscape of autoimmune neurology. It is now recognized that many of these antibody syndromes can be readily treatable with immune therapy, and some of these therapies overlap with treatment approaches used in MS, and some are very different. The discovery of new neuronal autoantibodies has revealed that these conditions are much more commonly than previously appreciated, and oftentimes patients are misdiagnosed or remain diagnosed. So how do patients present? Well, autoimmune and paraneoplastic disease can really masquerade as any traditional neurologic syndrome and have various presentations. Patients can present to various subspecialties, and autoimmune neurology intersects with multiple subspecialties in neurology. This includes epilepsy or seizure disorders, cognitive and behavioral problems, neuromuscular disorders. Patients can present with various forms of neuropathy, movement disorders including Parkinson-like syndromes, abnormal movements, or difficulty walking. Typically, when patients present, they present with a subacute progression of symptoms. This means symptoms generally occur over the course of weeks to months. Often there's a fluctuating course. Occasionally it can be more rapid or slower, depending on the clinical scenario. Different antibody syndromes can really affect almost any part of the nervous system. Sometimes it can be a multifocal presentation, meaning a patient could present with a movement disorder in addition to a peripheral neuropathy. So what part of the nervous system could be affected? Well, really any part of the nervous system. The focus later in the talk is going to be primarily, like I had mentioned before, on central nervous system diseases, meaning brain and spinal cord, but anywhere along the neuroaxis can be affected. So starting out, the brain, you can develop an encephalitis, which we'll go into more detail, but this is primarily presents with confusion and memory problems and seizures. The cerebellum can be affected. This is the balance center of the brain. You can get syndromes of cerebellar atrophy. This causes walking and visual impairment. The basal ganglia, which is deep in the center of the brain, when that's affected, you can get movement disorders. Again, things like Parkinson's disease or abnormal movements that are involuntary. When the brainstem is affected, you can have a very specific syndrome called opsoclonus myoclonus, which you get jumpy movements of the eyes and also the body. You can get a brainstem encephalitis, which can cause problems with double vision, weakness, and swallowing. The visual system can be affected, and this can cause retinopathies and optic neuropathies. Moving out of the brain, the spinal cord can be affected. When the spinal cord is affected, you get a myelitis or a myelopathy. Patients can present with weakness, sensory changes, bladder and bowel symptoms. Now taking a look at the spinal cord in cross-section, when nerve roots exit the spinal cord, that is the peripheral nervous system, that can be involved in autoimmune and paraneoplastic disease. Rarely you can get paraneoplastic radiculopathies as these nerve roots exit the spinal cord. There is a sensory ganglion right outside the spinal cord. When that is affected, you can get a disease that causes significant sensory impairment and loss of coordination. Very rarely, you can have mimics of anterior horn disorders, such as ALS. Again, when the nerve is affected, you can have peripheral neuropathies. There is a communication between the nerve and the muscle, which can lead to neuromuscular junction disorders, myasthenia gravis, Lambert-Eaton syndrome. And lastly, when the muscle is involved, you can get something like a myopathy. When there's inflammation of the muscle, this is defined as a myositis. And then lastly, let's not forget the autonomic nervous system. You can have involvement of the autonomic nervous system that affects the autonomic ganglion. This can cause various problems, the way the nervous system communicates to other vital organs. including the heart, which causes blood pressure and heart rate changes. When the nervous system talks to the GI tract or gastrointestinal tract, you can get dysmotility, which leads to symptoms like diarrhea and constipation. You can have loss of sweating and bowel and bladder dysfunction. Now, there are certain risk factors that can certainly provide clues to underlying autoimmunity. The coexistence of other systemic autoimmune disease can be a clue, and these include thyroid disease, type 1 diabetes, lupus, and other rheumatological diseases, such as Sjogren's disease or rheumatoid arthritis. Often there's a family history of autoimmune disease. There can be, again, as I had mentioned before, an association to cancer, so certain things that put you at risk for cancer, such as smoking, can certainly be risk factors. And sometimes it's also important to recognize that we just we don't have a risk factor, and there's no association that we can find. So we're going to move on to examples of very specific autoimmune neurologic disorders. We're going to start broad with just discussing encephalitis. Encephalitis, when patients present, they typically have memory problems, mood and personality changes, seizure disorders, and there's a diverse antibody association with this disease. On this slide here, this is a little snapshot of what I showed you previously. All these cell surface antibodies have been related to cause autoimmune encephalitis. So the diagnostic criteria for possible autoimmune encephalitis includes a subacute onset. Usually there's a fairly rapid progression that occurs in less than 3 months. And it's a rapid progression of mental status changes. Altered mental status is defined by, again, personality changes, fluctuation in consciousness, and also lethargy. Typically, there's at least one of the following symptoms found or signs found. One is a focal neurologic deficit, meaning weakness, sensory changes, vision loss. Seizures tend to be pretty common in the presentation. There can be evidence on spinal fluid studies or CSF showing inflammation. There can be changes on the brain MRI that are suggestive of encephalitis. And then additionally, it's important to rule out other potential causes of encephalitis, such as infection. So many patients with autoimmune encephalitis do not necessarily present with a well-defined clinical syndrome. However, there are some presentations that have very specific clinical syndromes or very specific radiographic or MRI findings. I'm going to talk about 2 of them in the next couple slides: limbic encephalitis and anti-NMDA receptor encephalitis. So limbic encephalitis is caused by inflammation of the limbic system. You can see here on the MRI that it has a very distinct radiographic finding on the MRI. These bright areas here in the mesial temporal lobe are abnormal. This is, again, a very distinct finding in limbic encephalitis. Occasionally, there can be areas of contrast enhancement. When you go in and you get your MRI, you can get an IV placed and given contrast. Sometimes the contrast is bright on the MRI, meaning there's some active inflammation and breakdown of the blood-brain barrier. Seizures are also very common in the setting of limbic encephalitis. Typically, these seizures come from the mesial temporal lobe here. And again, the mesial temporal lobe and the limbic system is very important in forming memories and emotions. So anti-NMDA receptor encephalitis, again first described in 2007. It's a syndrome of memory deficits, psychiatric syndromes, decreased consciousness, and hypoventilation or respiratory problems. Like I had said before, originally reported in 4 young women with ovarian teratomas, but really since that time there's been many cases reported in children as well as young to middle-aged adults, including men and women, with no association to cancer. It is also recognized as the leading cause of autoimmune encephalitis in children and adolescents. In fact, in the California Encephalitis Project, which was a project looking mainly at infectious encephalitis, the causes of encephalitis, 65% of patients were actually 18 years old or younger with NMDA receptors encephalitis. Here, I just show the picture of a recent popularized book called Brain on Fire. It is an autobiography by a New York Post writer, Susanna Callahan, and it describes her personal journey and struggle with NMDA receptor encephalitis. When she was 24 years old, she can recall waking up alone in a hospital room, unable to speak, or with no memory of how she got there, due to her devastating disease with NMDA. As she slowly recovered, she describes her personal experience with the disease, and an excerpt from the book stating, "What else have I forgotten? What else would come back, knocking me off balance and reminding me how tenuous my grip on reality was?" So here is a diagram that kind of shows this classic progression of NMDA receptor encephalitis. Again, it has a very well-defined clinical phenotype and is the most well-known and well-studied of all the autoimmune encephalitides. It has this classic progression, usually starting with a prodrome of a viral-like illness, so a fever, flu-like symptoms. After that, patients will have symptoms of psychosis, hallucinations, memory problems, many times seizures, and this progresses to causing movement disorders and eventually respiratory failure and coma. Patients usually respond quite well to immune therapy and need to be treated rapidly and often improve the reverse direction. Sometimes, depending on severity, it still can take quite a long time to recover. There are proposed diagnostic criteria for NMDA receptor encephalitis. Again, you have this rapid onset of less than 3 months, and typically at least 4 out of the 6 clinical syndromes that I've already previously described on the slide before this. But again, just to repeat, the psychiatric behavior, cognitive dysfunction, problems with speech, seizures, movement disorders, posturing, rigid, almost patients can appear frozen in place. You have this decreased level of consciousness, and usually at least one of the following diagnostic tests are abnormal, including an EEG, which is used to look for seizures, and again, CSF or spinal fluid studies show some evidence of inflammation. To define NMDA receptor and confirm the diagnosis, this is based on finding the positive NMDA receptor antibody in the spinal fluid. So in autoimmune epilepsy, seizures usually predominate the presentation. Again, these patients with autoimmune epilepsy, there's very much an overlap with the same types of antibodies that cause encephalitis. The presentation is just a little different, meaning more seizures than cognitive deficits. And often the clue is that these seizures are multifocal, meaning when patients get an EEG, they're coming from different areas of the brain. They tend to be refractory to standard anti-seizure medications. Now moving on of how to test for these diseases. When an autoimmune etiology is suspected, there's several tests that can be used to identify this. The diagnosis of autoimmune encephalitis or epilepsy is based on the overall clinical picture, and we look at various parts of the diagnostic workup. Sometimes we're lucky and we find a clear antibody, but many times an antibody, unfortunately, is not found. As our understanding of autoimmune encephalitis grows, we'll likely continue to discover new antibodies, and as you could see earlier, these antibodies are being discovered at a very rapid pace. Additionally, there are limitations to antibody testing, and not all the antibodies we recognize to cause autoimmune encephalitis or epilepsy are commercially available yet for testing. So the diagnostic workup usually includes spinal fluid studies or CSF studies, usually starting with some of the standard basics, blood work or serum studies looking for other evidence of autoimmunity. EEG, again, this is a test that we use to look for abnormal brain waves or seizures, and an MRI, which is our standard brain imaging. So if there are clues on the basic blood work or spinal fluid studies, or if there's a high degree of suspicion, then neuronal autoantibody testing should be sent. And ideally, this is sent on both the blood and the CSF. Again, clues to autoimmune encephalitis can include an abnormal EEG, looking again for this focal slowing spikes or seizures. The MRI can be abnormal. Again, the most common finding with those bright temporal lobes that I showed on the previous slide. And sometimes the MRI is normal. And when this happens, we can do other things such as a PET scan, which looks at the metabolism of the brain to further investigate. And so just to give you an example of what this can look like, on this screen here, I show the MRI and the PET scan. So for the MRI, this white arrow, and I'll show you also with the green arrow here in the mesial temporal lobe, if you squint really hard, you can see it's a little bit bright on that side and a little bit bigger compared to the other side. However, when you look at the PET scan, there's an obvious abnormality. So everything should be one consistent color here, and the arrows are pointing at this nice yellow bright spot. And so it was quite obvious here something wasn't right. Here's another example, an NMDA receptor encephalitis. Here you have a completely normal brain MRI seen on the right. And then on the left, this is the PET scan. So just to orient everyone, the PET scan, everything bright, red hot is a high metabolic state. Yellow is an intermediate metabolic state. And green and blue show low metabolic activity. Again, the cortex here of the brain that I'm outlining with the arrow should be all one consistent color. Instead, you can see here that there is relative low signal in the back part of the brain called the occipital lobe that's yellow, compared to the frontal lobes up here in the top part of the brain that's red, and this is a very specific finding that we see with NMDA receptor encephalitis. And then the last part of the workup, as I said before, sometimes cancers are a sign or seen in autoimmune encephalitis as a paraneoplastic syndrome. And so if an antibody-positive or antibody-negative autoimmune encephalitis is diagnosed, then there should be screening for any underlying cancer. When a specific antibody is found, sometimes that can help guide the cancer screening. And again, this is just reiterating certain antibody syndromes are more likely to be associated with malignancy than others. So moving on to treatment. Overall, treatment is based on expert opinion and retrospective studies. Treatment recommendations are mainly based off retrospective studies looking specifically at NMDA receptor encephalitis, since this is the most common autoimmune encephalitis and the most well-studied. Unfortunately, there's a current lack of clinical trials, and really there's no current standard of care. And so obviously there's a strong need for future studies in autoimmune encephalitis. Now this is a very busy slide, but I'm going to highlight a few things here in red in terms of treatment. So first, just starting out, there are two main treatment pathways highlighted on this slide: acute immune therapy and chronic immune therapy. First, acute treatments focus on high-dose IV steroids, right here. Also IVIG, which is IV immunoglobulin, which is essentially pooled antibodies from many donors, and we believe it works by neutralizing your own antibodies. Plex, also known as plasma exchange, and this can be thought of essentially a form of dialysis that filters out your antibodies. All these medications work quickly, but not the best medications to stay on long term. Occasionally, actually probably more frequently than we like, an antibody is not found, and sometimes these medications are used as a trial over the course of a few weeks to see if there's any benefit to the patient. And when we do these immunotherapy trials for a response, we can assess various objective tests to follow a response, included here, circled in blue. Now, when patients have a severe presentation, meaning they're in the hospital, in the ICU, or they're not responsive to the acute therapies, such as the IV steroids, IVIG, or plasma exchange, sometimes we use stronger immune therapies, and this includes rituximab and cyclophosphamide. Often rituximab is preferred since it does have a much better side effects profile compared to cyclophosphamide. And then moving on to chronic immune therapies. Now, this depends on the clinical response, disease severity, or if the patient has clinical relapses, or depending on the specific antibody that is found, we may need to continue chronic immune therapy. Again, given the side effect profile, often rituximab is continued outside of the acute setting and continued for every 6 months. While there's also oral medications that can also be used, such as azathioprine and mycophenolate. Often patients are not on immunotherapy indefinitely. If patients are stable, improve, sometimes we only continue these for 1 to 2 years and then taper patients off and watch them closely. Should they relapse again, then we would be readdressing with these same immune therapies. Again, lastly, let's not forget the malignancy screen as part of the diagnostic workup. Patients should have the cancer screening, and if a cancer is found, that becomes essential parts of the treatment plan. I'm going to move on to other examples of autoimmune neurologic disorders outside of encephalitis and epilepsy. So NMO, again, NMO, or neuromyelitis optica, was once thought to be a form of multiple sclerosis. Before the discovery of the aquaporin 4 antibody, and now since the discovery of the antibody, we know that it's its own separate autoimmune disorder distinct from MS. Again, patients present very similarly with optic neuritis, spinal cord lesions, as you can see here on the MRI. In contrast to MS, these spinal cord lesions tend to be a bit longer and located, what we say, centrally We also know based on, before the discovery of this antibody, patients were treated with traditional medications for MS, and patients with NMO do not respond to those traditional medications. Outside of rituximab, really there's not much overlap between the medications between NMO and MS. And so if patients are misdiagnosed or NMO is not diagnosed and they're treated with some of the traditional therapies for MS, they could have clinical worsening. And this slide here just kind of shows the treatment algorithm for NMO. Again, there's a component for acute immune therapy and chronic immune therapy. When patients present acutely, steroids are commonly used to treat urgently. Often plasma exchange or Plex is added if patients don't respond to steroids. This acute approach is very similar to what we see in MS. This is opposed to chronic immune therapy. Now, NMO has very similar attacks or relapses, such as we see with MS, and patients need to be on chronic disease-modifying therapy. However, like I said before, most current disease-modifying therapies that we use in MS don't work for NMO. And again, that's with the exception of rituximab. Rituximab has really become the mainstay of treatment for NMO. As of today, we do not have any published randomized double-blind clinical trials for NMO. However, this will be changing as we now have 3 clinical trials underway, which is quite exciting. There is a subset of patients with recurrent optic neuritis and spinal cord lesions that have a negative NMO antibody. And some of these patients we're starting to recognize and realize that is actually due to another antibody called anti-MOG. In fact, this antibody just became commercially testable over the last few months. And so we might actually see an increase in prevalence of this disease with just the ability to test. So moving on, this is going to be the last autoimmune neurologic disease that we focus on in this talk, stiff person syndrome. This was first described actually as stiff man syndrome by the Mayo Clinic in 1956 in the setting of a 49-year-old man with progressive stiffness in his neck, back, episodic painful muscle spasms, and difficulty walking. We now know that this syndrome affects both men and women, hence the terminology was changed to stiff person syndrome. And this disease is quite rare. It's considered a 1 in a million diagnosis. Immune-mediated mechanisms were suspected in stiff person syndrome. However, it wasn't until 1988 when the first documentation of anti-GAD65 antibodies were identified in association with this disease. Now we know that patients can have GAD65 antibodies, glycine receptor antibodies, or amphophysicin antibodies. The diagnosis relies upon clinical presentation, the presence of these antibodies, and specific findings on an EMG. Often patients with stiff person syndrome or GAD65 antibodies have other additional autoimmune diseases. Commonly, we can see type 1 diabetes, autoimmune thyroid disease, pernicious anemia, in which it's an antibody that interferes with B12 absorption in the gut, vitiligo, which is loss of pigment in the skin, as you can see in this picture here, celiac disease, Addison's disease. This is an antibody against the adrenal cortex. Antiphospholipid syndrome, which can sometimes be seen in the setting of lupus, and it's an autoimmune disease that puts you at risk for blood clots. Many times when patients come into the clinic, we're masking or screening for these additional diseases if they have GAD65 antibodies, and sometimes we even find that patients may have a family history of these other diseases, again providing an additional clue. So just to wrap up here, so we have some time for questions. Autoimmune diseases of the nervous system are important to recognize. The discovery of new neuronal autoantibodies has revealed that these conditions are much more common than previously appreciated, and it's not uncommon for patients to go misdiagnosed or remain undiagnosed. Again, as the increased awareness of autoimmune neurologic disease increases, it's more likely that patients will be diagnosed, and there will be a need to treat appropriately with immune therapy. Rapid diagnosis and early treatment is essential in the treatment of autoimmune neurologic disease. And in addition to rapid treatment for the best possible outcome for patients, it's also important to recognize that some of these diseases could indicate an underlying cancer, and screening is sometimes important. So I just want to take a moment to thank everyone for attending the webinar today, and all those future people who will watch it when it's recorded. And thank you to the Rocky Mountain MS Center for hosting this, and also a thank you to the Autoimmune Encephalitis Alliance for sending this out too. So I'm going to turn it over to questions.
Thank you so much, Dr. Piquet. We are going to switch over to the question and answer section now. So if you haven't already, please continue to submit your questions into the chat window.
All right, the first question we've got is, what do you think about infectious triggers beyond the proven HSV for autoimmune encephalitis? Are there more out there that we just haven't proven yet, or are concurrent infections a separate, unrelated immune system issue?
Yes, so that's a great question. We clearly see a relationship with HSV and autoimmune encephalitis, particularly actually with NMDA receptor encephalitis. In addition to HSV, in the setting of NMDA receptor encephalitis, we've actually recognized that other herpes-related infections, such as varicella virus, has also been shown to trigger autoimmune encephalitis. This is relatively new research. It's pretty much groundbreaking, and I suspect we will certainly continue to discover new viral relationships in the future. It's kind of oversimplified the definition of autoimmune disease, saying that, oh, it's just due to an overactive immune system. Rather, it's probably more of a dysfunctional immune system. So perhaps, again, these patients are predisposed to other viral infections. Additionally, outside of just this relationship of infectious triggers, it's important to recognize a lot of the medications that we use to treat these diseases can also open up patients to certain opportunistic infections. And so when patients present, we always have to have that in the back of our minds and make sure we're testing for those things.
Okay. Can you address B-cell and T-cell therapies? When to use them, when to repeat treatments? Do you repeat based on repopulation values or symptoms? And what is your approach to HD solumedrol after Rituxan to address an exacerbation?
So I think the HD might be IV solumedrol, so I'm going to interpret it as that. So just to back up, B and T cell therapies. So a little different than maybe how we think about these therapies for MS, but it's just kind of reminding people that you have these and I don't know if I can pull up this slide again, actually. It might take a while. I'll use this slide to just demonstrate what I'm pointing out here, because I left it on the key but didn't explicitly say it. So the black antibodies here are actually intracellular antibodies. Again, these are the traditional antibodies that we're seen with cancers or paraneoplastic syndrome. Again, oversimplifying things, and it's probably a little more complicated than what we realize, but these antibodies are thought to have a T-cell mediated pathogenesis, and so often when we find these antibodies, a broader immune suppressive drug is used. So examples would be azathioprine or mycophenolate or Cellcept. Both of these drugs work by acting on the T and the B cells. This is in contrast to all the antibodies shown here in red. These antibodies are cell surface antibodies. They are traditionally thought to bind to receptors and be reversible and have a direct pathogenesis. So these antibodies, we often use drugs targeting just the B cells because the B cells produce those antibodies, and if it's one of these misbehaving antibodies that it's producing, then if you get rid of the ability to produce those antibodies, we think that's how that basically works best. And then there was a part of that question on repopulation. So when we use rituximab is basically a monoclonal antibody, again targeting these B cells and leading to B cell depletion. We do have blood tests that we use called basically it looks at the it looks at the CD20 counts, and we do check that blood work sometimes to redose rituximab. Now, if patients are having an exacerbation and it's been a while, but their levels are still suppressed, but they're coming up due for the medication, say 5 months instead of 6 months, there can be rare circumstances where we do have to redose that, but every clinical scenario is a bit different.
I know you touched on this a little bit, but this is kind of a different way to look at it. We have one question where there's a variety of autoimmune disease in a family. We've got MS, Hashimoto's, Sjogren's, lupus. Has an autoimmune gene been identified that we could have all inherited? If so, could it be possible that it manifested in each of us with a different autoimmune disease?
Another great question. There's not one specific gene that we have identified, but clearly there is a genetic factor that predisposes you to developing autoimmunity, and that's why when patients come in, it's very important to take a family history. I'm often asking my patients, not only do they have a family history of MS, but family history of lupus, Sjogren's, thyroid disease, type 1 diabetes, because we do see a correlation with autoimmune disease in the family in the setting of these diseases.
How can family members in a home setting most assist in the recovery from AE?
So autoimmune encephalitis is a difficult diagnosis. It causes, like I said, memory problems, personality changes, and that can be very difficult because you're looking at someone in front of you that is not the same person that they were 6 months ago. And I think, the biggest thing for family members is really understanding the disease and understanding that their loved one doesn't have necessarily the control, they're saying things that they don't necessarily mean. So I think education is a big component to help assist family members in their understanding.
Okay, some questions from the live audience today.
Mm-hmm.
I was diagnosed with CREST syndrome in the early 2000s by an ANA test. Considering the new testing available, would it be helpful to do retesting now?
So yes, our testing has become better and better every year. So I've certainly gone back and retested patients. CREST syndrome is related to scleroderma, which doesn't typically have specific neurologic involvement. However, there are those very rare cases. But yes, I think that's something that newer testing, especially if symptoms are atypical or things are progressing, retesting would be something to consider.
All right, second question. Is it critical to have an FG PET scan, or is a regular PET scan sufficient?
Oh, so the FDG PET is the PET scan I was referring to. I'm sorry.
One more. Is anti-NMDA encephalitis the same as Hashimoto's encephalopathy?
No. So Hashimoto's encephalopathy was actually defined before the discovery of some of these neuronal antibodies, specifically NMDA receptor encephalitis. So much of what we used to call Hashimoto's encephalopathy, say 25 years ago, some of these are actually very specific syndromes now, NMDA receptor, LGI1. We are finding these antibodies. Hashimoto's encephalitis was traditionally defined based on thyroid antibodies that we found in the serum. And it's probably, what I typically do in terms of my clinical approach is when patients do have very high thyroid antibodies in the serum in the setting of confusion and encephalitis, it's essential that you actually go back and make sure you've completed the workup with a lumbar puncture, looking at, again, these neuronal autoantibodies, because it may just very well be, like I said before, an overlap syndrome. So, for instance, GAD65 antibody syndromes, thyroid disease is very common.
All right, this one just came in. Do you know if there's a difference between the dopamine receptor 1 and 2 antibodies? No.
Wait, which? Oh, here.
See that one?
Yeah. Dopamine receptor 1 and 2 antibodies from the Mayo Clinic. So this for everyone, I can read the question here. Do you know if there's a difference between the dopamine receptor 1 and 2 antibodies on the Mayo Clinic autoimmune encephalopathy panel? Do those differ from the testing on the Cunningham panel, or are they the same thing? This gets into very specific nuances in the field with testing that can be very difficult for not only patients but clinicians to understand. The Cunningham panel is not a typical test that I use in my diagnostic workup. There has been some debate and conflicting literature that I still think we're learning about. I do use the testing through the Mayo Clinic currently, as they are the laboratory in the United States that has the most comprehensive and broad testing available.
So another question that was submitted ahead of time. If a male aged 23 is experiencing auditory hallucinations for the first time that came on all of a sudden, could this be related to an autoimmune antibody-mediated disease? If so, what's the first step to be taken to determine this?
So with just auditory hallucinations, it could be. It could also be a primary psychiatric disease or neurologic in origin. So the important part really is for the patient to have a thorough neurological workup, and what this includes is a detailed history. Again, not only the patient's history, but clues from the family history of autoimmunity, and then a detailed neurologic exam to help identify is there any abnormalities here that should prompt additional testing, meaning MRIs and some blood work, as I had mentioned in the presentation. There's another question here: is NMDA curable? So yeah, it can be treatable. So patients, as I described that algorithm of treatments, NMDA receptor encephalitis is very responsive to immune therapy, and rituximab works really well. It's going to be important to recognize patients just do better when they're treated earlier in the disease course. And I certainly have had patients that are essentially almost back to 100%, back in the workforce and doing quite well. The key component to that is it can take time. It can take time to recover. And when I say time, I'm not talking days. I'm talking it can take a year or two. And, you know, we always watch patients closely. As I said, we sometimes continue our therapy 1 to 2 years, taper off, and about 25% of those patients are at risk for relapse. But yes, it can be very treatable.
Excellent. And then do you have any suggested diet, paleo, keto, Wall's protocol?
So in terms of diet, there's not a magic diet that I have that's going to completely cure or reverse autoimmune disease alone without the immune therapy. However, I believe it is a very important component to the overall treatment plan. A healthy diet is essential for total brain health. We know patients with MS do better with diets low in salts, saturated fats, sugars. In fact, you know, much of the medical literature is lagging in terms of our clinical trials and our studies in diet. But what's exciting is that there was actually just a recent publication on this in the Neurology Journal last month showing that what we believed in MS is actually true with the low salt and low saturated fat diets and healthy living.
Excellent. Thank you so much for sharing this information on neuroimmunology and your time, and thank everyone for tuning in and submitting questions. After you close the webinar, you will see a short survey. Please take a moment to let us know your thoughts. We do evaluate all of the feedback that we receive. And you can find additional educational resources on our website, www.mscenter.org.
No, thank you everyone again for phoning or videoing in. Thank you for your time.
Thanks.
Thank you. Please stand by.